The Subcommittee on Health of the Senate Finance Committee will come to order. Our hearing today is Aging in Place, the vital role of home health care and access to care. First, I want to start by thanking Senator Daines for his help and cooperation in putting together this hearing. I think there's a great deal of interest among both Democrats and Republicans on this subject, and I thank him for his help. And I want to thank Senator Wyden and Senator Crapo for allowing the subcommittee to hold this hearing and for the help in arranging for the witnesses and for the preparations for the hearing. So thank you, Senator, our chairman. We appreciate that very much. The CDC defines aging in place as the ability to live in one's own home and community safely and independently, comfortably, regardless of age, income, or ability level. I must tell you, when I meet with seniors, which are my contemporaries, their number one fear many times is the fact that they're not going to be able to stay in their community. They are going to be put in an institution, a nursing home. And they point out that if they do that, the government picks up a large part of the cost. So what they want to do, they want to stay in their homes. They want to stay in their communities. But they believe they're going to be forced into an institution because of the lack of other options. We have excellent continuing care facilities, but they're beyond the financial reach of most of our seniors. Now, there's been some excellent examples of communities coming together for aging in place, and I want to give a shout out to my own community in Baltimore, which over a decade ago established a government-private partnership for aging in place and sponsored by the Associated that became a national model. We have those individual examples where we've been able to combine private resources with government resources to help our seniors age in place. They recognize that if they can stay in place, that's their preference. It's less costly, it gives them more dignity and a better quality of life. But the number one challenge, in my view, is the failure of our nation to have a coordinated long-term care strategy. We don't. Our committee has jurisdiction over the health care components of Medicare and Medicaid, but it goes well beyond the jurisdiction of our committee. And because of the lack of a coordinated policy, seniors often end up in a more costly environment, in a less desirable environment, and I would suggest a more dangerous environment for their long-term health. And that's what the purpose of this hearing is, to go over the federal role under the jurisdiction of our committee, the Medicare and Medicaid programs. We have, under Medicare and Medicaid, home health care services that are provided. They're recommended by healthcare professionals and carried out by healthcare professionals. They may be issues such as wound care or physical, occupation, or speech therapy or injection and nutrition therapies. And in 2021, 3 million Medicare beneficiaries participated in home health services. About a quarter of those got those services after a hospital or institution post-acute care setting. So what are the challenges within the confines of the home health services? Well, first is workforce. Can we get the people to provide those services? And that's been complicated greatly because of COVID-19. COVID-19 just underscored the challenges we had in our healthcare workforce. They're frontline workers, and we need them. And it was a challenge during COVID, and we're still suffering from a tight labor market and having the trained people to be able to carry out those services. But I would also suggest that the reimbursement structure is added to the challenges for people being able to get the home health care that they need. It's a complicated formula, so I'm not even going to try to outline it here today. Maybe some of our witnesses will talk about it. But it's a challenge. But I do know this, that it, in many cases, did not offer the appropriate incentives for access to care for people for home health care under Medicare. And then we have, equally important, the non-medical benefits under Medicaid, the assistance with activities of daily life, ADL, such as bathing, dressing, the transportation, meal preparations, and the list goes on. And they're generally provided by home health or home care aides. In 2021, 1.9 million Americans participated in the program. And they have a similar problem that we have with the home health medical services, with providers, a shortage of providers, very difficult to get trained people in this field. And we also have a reimbursement issue as to whether we're going to get access to care. So we have challenges in both the health component and in the assistance with activities of daily living. And I hope that we'll have an opportunity to talk about that with the witnesses we have today. There are long wait lists to get home health services. In my state, for the non-medical benefits, we have 30,000 on the wait list. That's unacceptable. We can do better than that. So I recognize the challenges we have with a coordinated long-term care strategy for our nation, but we can do better in the Medicare and Medicaid programs in providing home health services. We're not optimizing the opportunities. And I hope this panel of witnesses will help us in understanding that and what we can do and recommending changes to the system that will provide greater access for services that our constituents desperately need and want. I want to thank all of our witnesses for being here today. I'll introduce you shortly, with the assistance of at least one of my colleagues. But now let me yield to Senator Daines.
Chairman Cardin, thank you, and a big thank you to our witnesses for being here this morning for a conversation on home health. The home health benefit is a critical component of the Medicare program, and it is of increasing importance as our nation's senior population continues to grow. In fact, in my home state of Montana, 20% of our population is age 65 and older. In fact, Montana is currently ranked 6th in the nation for states with the highest percentage of residents aged 65 and older. And we know from countless surveys and research that Americans overwhelmingly prefer to age in place, which allows them to remain in the comfort of their own homes, preserve their quality of life and dignity, and retain their independence to the greatest extent possible as they grow older. Home health care plays an essential role in allowing our nation's seniors to do just that, to receive certain essential health care services in their homes where they are most comfortable. However, facilitating this kind of care comes with a number of unique challenges not found in a traditional institutional health care setting. For example, accounting for the time and the resources staff need to travel in order to see patients in their homes. And we're in more rural states like Montana, that's a really big deal. As so often the case, the difficulties of providing care to patients at home are only exasperated when you get to more rural type environments. Earlier this year, the committee hosted a thoughtful discussion on the opportunities and obstacles that exist when it comes to facilitating health care in rural communities across the country. Many of the concerns raised in that hearing, including access, transportation, and of course the big issue of workforce, are applicable to administering home health care in rural states as well. I'm glad we are joined today by panelists who can speak to these particular challenges as well as the nuances. Another value and intention of the home health benefit is the aim to be cost-effective. By offering services such as skilled nursing, physical therapy, and occupational therapy in the home, the benefit can help provide savings to the Medicare program by avoiding unnecessary and costly institutional care. As we are all aware, the Medicare Hospital Insurance Trust Fund is fragile, and the rampant inflation over the past several years has had devastating effects throughout our economy. The healthcare sector in particularly has felt these pressures deeply. Going forward, we need to consider how the benefit can continue to be administered effectively while also ensuring patients are able to receive the care that they need. The concept and the benefit of home health has evolved significantly since its inception in 1965. That was a long time ago, Chairman. As Congress deliberates the future of home health, we need to be thoughtful as to what the benefit should look like, how it can best continue to serve America's seniors, and our ultimate goal is to make certain that patients are able to receive the right care, the right time, in the right setting with appropriate payment. Not an easy task, but I'm glad we have the opportunity to dive into these topics today. Thanks again to our witnesses for making the trip here, for being with us to lend their expertise, their experience, this conversation. I look forward to the discussion. Mr. Chairman, I'll turn it back to you.
Thank you very much, Senator Daines. I'll now recognize the chairman of our committee, Senator Wyden, who's been a real champion on home health and on moving forward on our healthcare system, and has been responsible for a lot of action in our committee to improve access to healthcare and affordability of healthcare. Senator Wyden.
Thank you very much, Chairman Cardin and Senator Daines. We've got a terrific bipartisan duo here, and I'm going to talk just very briefly and close by mentioning the committee's bipartisan tradition in tackling home health care, and just make a couple of points very quickly. The first is, it is very rare in the public policy field where you have an opportunity to make sure that families and communities get more of what they want, which is care at home, than the alternative, which is institutional care. And since my days as co-director of the Oregon Gray Panthers, I've always thought that this was a pretty straightforward proposition. When people ask about the costs of designing home health care services, I always say, you can't afford not to. You can't afford to pass up this kind of option, giving people more of what they want at less cost to taxpayers. So that's number one. Number two, now is exactly the time for us to look at this issue beyond the next few weeks and towards the long term. We all know that Medicare has some long-term challenges. We've seen in the papers recently that the rate of growth has subsided a little bit. I like to think that the Affordable Care Act has something to do with that. We also know that the challenges are real. So I'm only going to wrap up with this, Chairman Cardin. If you look down towards the last few seats in the dais on the Republican side, you'll get a little sense of the history, because Senator Olympia Snowe, Republican of Maine, was a great champion of home care. Where Catherine Cortez Masto is sitting, there was a senator from the other end of the country who had a full head of hair and rugged good looks. And that was me. And we were always talking about home health care. So I would just make an appeal to Chairman Cardin and Senator Daines. Let's pick up on the bipartisan tradition in the Senate Finance Committee of pursuing long-term solutions to big health issues. Let's do for this, colleagues, what we did for chronic disease, where we moved Medicare from being an institutional program to also focusing on cancer and diabetes and heart and stroke and all the chronic conditions. We've got excellent leadership in Chairman Cardin and Senator Daines, and I very much look forward to them. And by the way, before we wrap up, let's take note of the fact that Senator Stabenow, who unfortunately I can't talk out of retirement, has also been a terrific advocate on these issues. So I look forward to working with my colleagues.
Thank you, Senator Wyden. I'm glad you acknowledged Senator Stabenow, who was the previous chair of the subcommittee, and the work that she did. We're carrying on in that legacy, so let me thank our colleagues for the work that they have done. I want to now introduce our 5 witnesses. I'll introduce all 5 in the order with the help of Senator Cantwell with one. And after the introductions, you'll be able to give your opening statements. We'd ask that you limit it to around 5 minutes so we have time for exchanges. And without objection, your full statements will be made part of the record. We will start with Carrie Edwards, who received her BSN in 2002 from Creighton University and obtained her MHA in 2013 from Bellevue University. Carrie was employed by the Mary Lanning Healthcare for 24 years, currently working as the Director of Home Care since 2010 and has worked in home care arena since 2004. Carrie started as an aide in the private duty agency in 1999 and enjoyed spending one-on-one time with patients and their families. And I understand that you brought your daughter, Caitlin, with you today. Hello, Caitlin. It's nice to have you in our committee. And if I'm correct, I think your class is streaming this hearing, so we have a larger audience. Thank you for giving us a larger audience. We appreciate that very much. And we have our second witness is Mrs. Judith Stein. is the executive director of the Center for Medicare Advocacy, which she founded in 1986. She has focused on legal representation of older people since beginning her career in 1975. From 1977 until 1986, she was the co-director of the Legal Assistance to Medicare Patients, where she managed the first Medicare advocacy program in the country. She has extensive experience in developing and administrating Medicare and related advocacy projects and conferences, representing Medicare beneficiaries, producing educational material, teaching, and counseling. She is the author of the Medicare Handbook, so we have a lot to learn from Mrs. Stein's presentation. Our third witness is Ms. Tracy Morose, which I'll yield to Senator Cantwell.
Thank you, Mr. Chairman, and thank you for this important hearing. I would like to introduce Dr. Tracy Rose from the University of Washington. She's an associate professor in the Department of Rehabilitation Medicine at the University of Washington School of Medicine. This is an important institution in our country because it is the #1 production of primary care physicians in the United States of America, which is, as I'm sure Dr. Rose will tell you, how important it is to have the actual physician productivity to see this growing population. She is a health service researcher and background occupational therapist, and she spent her academic career conducting research on access and quality of the home healthcare system. So I think she'll be able to give us a pretty broad range of how those issues are changing, particularly home healthcare in rural communities. And her impressive work has received funding from the National Institute of Health, the Health Resources and Services Administration, the Agency for Healthcare Research and Quality. And just like my colleagues, I'm anxious to hear the panel overall, but particularly Dr. Rose on this issue of the fact that our population reaching 65 and older is expected to double in the next 30 years. And so we have a big challenge here, particularly not just on the production of physicians and the home delivery, but actually homes. If we don't have affordable housing, we don't have a way to keep them in their home. And my guess is we will have a much more expensive Medicaid budget because of it, because then people will be in assisted living, and then it will be more costly. So this is a really important task for us. So I very much appreciate your Master's of Science in Occupational Therapy and Doctor of Philosophy and Health Services research from Johns Hopkins. So we look forward to hearing your thoughts on how we tackle this very important quality of healthcare issue, workforce issue, housing issue, and certainly impact on our federal budget issue. I definitely think this panel can lead us to more affordable solutions for both the residents we're talking about, but also for our government as well. Thank you.
Thank you, Senator Cantwell and Senator Rose. Welcome. Dr. Rose, welcome. Don't want to promote you to that, or demote you, one of the two. Mr. William Dumby is the president of the National Association of Home Health Care and Hospice. As a key part of his responsibility, Bill specializes in legal, legislative, and regulatory advocacy on behalf of patients and providers of home health and hospice care. With over 40 years of experience in healthcare law and policy, Bill Dumby has been involved in virtually all legislative and regulatory efforts affecting home care and hospice since 1976, including the expansion of Medicare home health benefits in 1980, the formation of the hospice benefits in 1983, the institution of Medicare PPS for home health in 2000, and the national health care reform legislation in 2010. So we can blame you for all the problems it looks like that we have in the system. Dr. David Grumbowski is the professor of healthcare policy at Harvard Medical School, where he studies long-term care and post-acute care. He published over 225 peer-reviewed studies on this topic. He is a former member of the Medicare Payment Advisory Commission, MedPAC, and has served on several CMS technical expert panels, including one related to Medicare home health care payments. As you can see, we have real experts on this subject matter, and I just want to underscore what Senator Wyden said. We look forward to your suggestions as how this committee can proceed in a bipartisan manner to provide the type of services that the people of our community want in home health care. We'll start with Mrs. Edwards.
Chairman Cardin, Ranking Member Daines, and members of the committee, thank you for the opportunity to testify at this important hearing focusing on the Medicare home health benefit. I would like to thank Senators Stabenow and Collins for their unwavering support to ensure that Medicare beneficiaries have access to high-quality home health services by introducing Senate Bill 2137, the Preserving Access to Home Health Act. I encourage every senator to join as co-sponsors. My name is Carrie Edwards. I serve as the Director of Home Care Services at Mary Lanning Healthcare, located in Hastings, Nebraska. Our home health agency is a hospital-based, nonprofit, rural provider. At Mary Lanning Home Health, we have over 50 years of experience bringing healthcare services into the homes of central Nebraska residents. We offer a variety of services to meet patient needs right in front of the comfort of their own home, including skilled nursing, physical, occupational, and speech therapy, lymphedema therapy, medical social work, and home health aid services. From my nearly 25 years of experience in the home health field, I can confirm that home is where the heart is. Most of us just feel better when we are at home. That's why I fell in love with helping people stay in their homes, even when facing significant health challenges. But our ability to deliver patient-preferred, high-quality, cost-effective, life-saving home health services is in jeopardy, and not due to any service failures of Mary Lanning Home Health, but rather because of decisions being made right now by CMS that threaten my home health agency and thousands of other agencies across the country. Our long history of service to the residents of Nebraska is at risk due to the significant payment reductions that CMS started in 2020 with the new payment model. Mary Lanning Home Health previously covered a 13-county, 60-mile radius of Hastings located in Adams County. In March of this year, we had to decrease our service area to a 40-mile radius. Several months later, in May, we had to make the difficult decision to further reduce our service area to only cover Adams County, which covers a 25-mile radius, including the city of Hastings. Some of the previous counties that we once served no longer have coverage by any home health provider. So far this year, we have declined services to 50% of the referrals we have received because those 55 referrals fell outside of our reduced service area. Our average daily census count reduced by more than 60% since the implementation of the new payment model, from an average of 88 patients in 2020 to a census count in September 2023 of 32. CMS's actions are also having a direct impact on our ability to retain our existing workforce. We've had 3 registered nurses resign due to fear that the looming payment cuts being proposed by CMS will force our agency to close. The 3 nurses did not leave nursing. Instead, they went to work for other healthcare providers rather than risk remaining with Mary Lanning Home Health. Hospitals are seeing higher acuity patients than in previous years, and our agency is providing more intensive home health services to a population that has more complex needs and increased comorbidities. When a patient isn't able to be admitted to our home health agency, the result is either longer stay in the hospital, placement in a skilled nursing facility, or foregoing care altogether. I am very proud of the quality of care we provide at Mary Lanning Home Health. In 2022, our home health agency prevented 93.5% patients we served from being readmitted to the hospital, averaging a low 7.6% readmission rate that was well below the state and national averages. Year to date, we have prevented 93.7% of the patients we serve from being rehospitalized. And our patients have been extremely satisfied with our level of care, as we have a 5-star patient satisfaction rating on Home Health Compare. As we look to prepare for 2024 with the pending payment reductions that CMS has proposed and the potential for payment reductions spanning past 2030, we are doing everything possible to remain operational. There are agencies throughout Nebraska and the country that are at serious risk of closure. If I can leave the committee with one takeaway from my testimony today, it's that CMS and policymakers should be finding every way possible to make increased investments in Medicare home health services instead of the current path of year after year payment cuts that are jeopardizing my agency's ability to care for Medicare beneficiaries and for me to continue my calling to service so that Nebraskans can safely recover at home, where most of us just feel better. Thank you.
Thank you very much for your contribution. Mrs. Stein?
Good morning, Chairman Cardin, Ranking Member Daines, and distinguished members of the committee. Thank you for inviting me to testify today. I'm Judith Stein. I'm the founder and executive director of the Center for Medicare Advocacy. The center is a national, private, nonprofit, nonpartisan law organization based in Connecticut and Washington, D.C., with attorneys in Maryland, Massachusetts, and California. The center works to advance access to comprehensive Medicare coverage, quality health care, and health equity. We provide education and direct legal assistance to help Medicare beneficiaries throughout the country. Among other things, we respond to 7,000 calls and emails annually and pursue thousands of Medicare appeals of wrongful denials of coverage and care. Our policy work is based on the real-life experience of the beneficiaries and families we hear from every day. Our healthcare system is in dire need of reform, including Medicare. We have many ideas about how to do so, and I'm sure my fellow panelists and members of this committee do too. And while there are many improvements to the Medicare home health benefit that I would like to recommend, when it comes to the Medicare home health benefit, my main message today is simple: enforce the law that already exists. Currently, this is not the case. Instead, Medicare home health coverage is incorrectly understood and implemented as a short-term acute care benefit by those who administer the Medicare program, home health providers, and those who make Medicare coverage decisions. Under the law, Medicare home health coverage can be an important resource for Medicare beneficiaries who need health care at home. When properly implemented, the Medicare home health benefit provides coverage for a constellation of skilled and non-skilled services, all of which add to the health, safety, and quality of life of beneficiaries and their families. Under the law, Medicare coverage is available for people with acute and chronic conditions, and for services to improve or maintain or slow decline of an individual's condition. Further, coverage is available even if the services are expected to last over a long period of time. Indeed, with an intent to expand home health services, in 1980, Congress removed a 100 home health visit cap in the Omnibus Budget Reconciliation Act of 1980, removed a cap of 100 visits. Congress again recognized the ongoing nature of Medicare's home health coverage in the Balanced Budget Act of 1997, when it established a Medicare prospective payment system that recognized the benefit was not just short-term, and it arranged for payments under Part B for people who have both Part A and B for more than 100 visits, and arranged that if people do not have Part B, more than 100 visits will be paid for under Part A. Federal regulations and Medicare policy reiterate that there is no duration of time to the Medicare home care benefit. The center, unfortunately, hears regularly from people who meet Medicare coverage criteria but are unable to access Medicare-covered home care or the appropriate amount of care. Perhaps most glaringly, access to Medicare home health aides is disappearing. Home health aides provide help with personal hands-on care. The care is often key to the well-being of patients who want to age in place, as well as for their families and caregivers. Unfortunately, Medicare beneficiaries are often misinformed about Medicare home health coverage in general and home health aides in particular. They are told that it's for a short term, for a few weeks, for a bath from the home health aide, just for 1 to 3 times a week. Under the law, Medicare authorizes 28 to 35 hours a week of home health aides' personal hands-on care. Instead, this care is being shifted to state Medicaid programs and families. Currently, statistics demonstrate the dramatic change in coverage. Home health aides utilization declined steadily over the past 2 decades by almost 94%. Access to the full array of Medicare-covered home health services is lacking for beneficiaries in traditional Medicare, but it's even worse for those enrolled in Medicare Advantage. In 2021, the Center surveyed 200 home health agencies across 17 states about Medicare-covered care. When we asked the home health agencies whether things were worse when their beneficiaries and patients were enrolled in Medicare Advantage, they said Medicare Advantage plans often fight tooth and nail on the number of visits they will allow. That was a home health agency in Connecticut. There's a difference. Medicare Advantage don't approve as much services, said an agency in Louisiana. Freaking-lutely, Medicare Advantage plans in our area are rotten, said a provider in Kansas. Today, Medicare payment policies, oversight measures, audits, and quality measures create disincentives to provide necessary ongoing home health care. These policies and practices must be reviewed and revised by Congress and by CMS. They must be geared to ensuring that public Medicare funds are actually used to provide the full array of home care for all people who qualify under the law. Congress must ensure that Medicare's home health payment model is structured to encourage home health agencies to provide all these services for all who qualify. If the law was properly understood and implemented, vulnerable Medicare beneficiaries would be able to obtain the care they need to live well and safely at home. If the law was properly enforced, there would be positive transformational change for older people, people with disabilities, and their families throughout the country. Thank you, and I hope you'll read my testimony, which I've prepared with a long bibliography of all we've written about this incredibly important benefit. Thank you so much.
I've enjoyed your testimony so much, I'll read them full statements. So thank you very much. I appreciate that.
Thank you.
Dr. Morose.
Good morning, Chairman, Ranking Member Daines, and distinguished members of the committee. My name is Tracy Rose, and I'm an associate professor in the Department of Rehabilitation Medicine at the University of Washington. Thank you for inviting me to provide testimony about opportunities and challenges for home health in supporting aging in place. I will focus my comments today on the role of home health for aging in place, disparities in access to home health in rural communities, and key drivers of access to care. Medicare's home health benefit provides an opportunity to support aging in place for the 3 million beneficiaries who receive home health annually. Admission to home health following a hospitalization, known as post-acute home health, helps bridge the transition from the hospital back to home. Admission to home health directly from the community, known as community entry home health, supports beneficiaries with chronic conditions who experience a change in health or functional status that doesn't require hospitalization, but would benefit from services to promote recovery, stabilization, or prevent further decline so the beneficiary can remain safely at home. Both post-acute and community entry home health are crucial for rural beneficiaries because they tend to be older and are in poorer health compared to their urban counterparts. But the promise of home health to support aging in place relies on the beneficiary's ability to access this care. While the vast majority of beneficiaries live in communities served by at least 2 home health agencies, the reality of access to home care for rural beneficiaries is far more nuanced. The number of agencies serving a community represents supply, which is a necessary but not sufficient measure of access to care. Rural agencies may refuse referrals for new admissions when they don't have adequate capacity. For beneficiaries who are admitted to home health, visits may be delayed or reduced due to the amount of what we call windshield time, which is the travel time that's required when patients are dispersed widely across large geographic areas. So it's perhaps unsurprising that there's a growing body of evidence on disparities in access to home health based on rural-urban status. Rural beneficiaries are less likely to be discharged to home health following hospitalization, and beneficiaries in the most remote rural communities are at the highest risk for unmet need. Further, fewer than 60% of rural beneficiaries with a plan to discharge to home health actually receive this care. Even when rural beneficiaries are admitted to home health, they face disparities in access to specific services. Rural beneficiaries who experience a stroke or have a knee replacement are less likely to receive rehab services, despite the essential role of rehabilitation for these patients. Adequacy of financial resources and health workforce are 2 key drivers of access to home health for rural beneficiaries. Please refer to my written testimony for additional factors. rural agencies cannot serve their communities without adequate resources. Even though average Medicare margins for agencies are high, more of the agencies that serve rural communities are nonprofit or governmental versus for-profit, and hospital-based versus freestanding. These distinctions are important because margins tend to be lower in nonprofit and governmental agencies, and hospital-based agencies often rely on their relationship with the hospital to remain financially viable. In recognition of extra costs required to serve rural beneficiaries, Medicare has intermittently provided a percentage increase in payments to home health agencies for providing that care. Rural add-on payments may help maintain supply of agencies serving rural communities and even reduce hospitalizations, but these payments have decreased over time and are being sunsetted. Agencies are also navigating other changes that impact Medicare reimbursement. The patient-driven groupings model implemented in January 2020, shortly before the emergence of COVID-19, presents a major redesign in reimbursement that can disincentivize community entry home health, longer stays, and rehab service provision, which in turn may hinder opportunities to support aging in place for the most vulnerable beneficiaries. Further, the national rollout of the home health value-based purchasing model is underway, putting lower quality agencies at risk for severe financial penalties. This is problematic when rural beneficiaries have no other options for care. Access to home health also depends on successful recruitment and retention of qualified workers. Rural agencies have cited multiple barriers to recruiting and retaining staff, including geographic isolation, unreliable transportation, and wages that are not competitive with rural hospitals and similar jobs in urban areas. The home health aide workforce is much lower per capita in rural communities and is particularly fragile due to low wages, unpredictable hours, and emotionally and physically demanding work. Policies to support this workforce are urgently needed because without a workforce, there is no care. In conclusion, the Medicare home health benefit is currently supporting beneficiaries' ability to age in place, but the full potential of home health has not been realized, particularly for rural beneficiaries. Research suggests the need for targeted solutions that incentivize service provision for beneficiaries at risk for reduced access and poor outcomes. As agencies continue to adapt to multiple policy changes and emerge from the public health emergency, it's essential to monitor the stability of rural agencies and its impact on rural beneficiaries. Thank you, and I look forward to the discussion.
Well, thank you very much for your testimony. Mr. Dumby?
Good morning, Chair Cardin, Ranking Member Daines, and the remainder of the House Subcommittee on Healthcare. I want to thank you for the opportunity to present my views on the vital role that home health services plays in our continuum of care and the challenges faced today in preserving access to these essential services. I currently serve as president of the National Association for Home Care and Hospice, and I can proudly say I was co-director with Judy Stein years ago in Medicare advocacy in Connecticut. I come to you today to present information on the state of the Medicare Home Health Services benefit. I may bore you with some statistics, but I think they're necessary numbers to hear. While it continues to provide significant care support for millions of beneficiaries each year, the home health agencies providing care and beneficiaries receiving care really need your help. The Medicare home health benefit covers an increasingly essential service, and as Senator Wyden referenced, it is one of the areas that has brought the parties together both in the House and the Senate over many years. We actually have a poster in our office exemplifying that. Notably, it's the only benefit available under both Medicare Part A and Part B, and Congress has implemented and enacted improvements in the benefit design standards and coverage and care for many years. These improvements include the elimination of cost sharing on services to incentivize patients to select care in the home, extending the scope of coverage to an unlimited number of service visits for the same purpose, refining the definition of confined to home to allow non-medically related absences from the home, such as attending religious services, and establishing patient rights, quality of care measures, and compliance standards that ensure care quality. The benefit is quite a wide coverage area in skilled nursing, therapy, medical social services, home health aid services when meeting all the eligibility standards. These services are available to patients without regard to whether their condition is acute, chronic, or at end of life. While the benefit design and standards of coverage present a valuable Medicare benefit, in practice, the benefit's trajectory is deteriorating. Since 2011, Medicare beneficiaries have experienced reductions in care and losses in care access not experienced in other sectors. Statistics on your way. In 2011, 3.5 million users of home health services received an average of 36 visits per year. 10 years later, after changes in payment model, only 3 million users, 500,000 fewer patients were served receiving home health services. A drop in average visits also accompanied that to 25.4, 500,000 people less 10 years later receiving services. Since 2011, the number of home health agencies also has dropped by over 1,000 nationwide. Rural areas have been especially hit hard, as the testimony of Carrie Edwards suggests, but it's not just rural areas. Inner cities, causing great disparities in access to care, are losing home health services as well. Senator Cardin, in Baltimore, it takes security escorts in order to bring home health care to some of the neighborhoods in Baltimore. They deserve the care, and the caregivers deserve the security of doing so, but it has reduced access to care in the end. Medicare spending data shows the same roller coaster journey of the benefit. Home health spending today is virtually the same as it was in 1997, despite 24 years of cost inflation. In 1997, Congressional Budget Office estimated that 10 years later, $40 billion a year would be spent on home health services. It's still under $17 billion a year, all these years later. It's a telltale that we cannot continue to see happening. In comparison, inpatient hospital spending rose from $80 billion to $130 billion, while skilled nursing facility care, what home health is trying to avoid, rose from $11 billion to $27.2 billion. The future presents an outlook that calls for significant action from all stakeholders. The correlation of payment cuts and reduced access is obvious and ominous. There are several signs that the existing difficulties in care access will continue. The American Hospital Association reports significant increases in the length of stay due to the inability to place patients in home health services. Patient referral rejections have increased by 50%. Only 55% of referrals are actually being converted to patient admissions, and only 67% of discharges from hospitals actually result in admission to home health services. CMS data shows that 52.7% of freestanding home health agencies are projected to have financial margins below zero with the cuts proposed for 2024. It is overall financial margins that really measure financial stability, not the incomplete analysis presented by MedPAC. Medicare margins, to the extent they exist, are subsidizing other payers like Medicaid and Medicare Advantage. Care is going to patients, not into people's pockets. To restore and preserve the Medicare Home Health Services benefit, we offer the following recommendations. Number one, Congress should pass S-2137 and H.R. 5159, the Preserving Access to Home Health Act of 2023, and we strongly support and applaud Senator Stabenow and Collins for bringing this legislation to the Senate. CMS should withdraw its proposal for the significant cuts in Medicare payment rates scheduled to take effect on January 1st, 2024. They have the authority to do that. And Congress should mandate the development of a comprehensive analysis of the root causes of the ongoing deterioration of the home health services benefit. Thank you for the opportunity to present this testimony. I look around this room and I see senators who, if they take a look at what's going on in their states, they'll see closures. Senator Hassan, New Hampshire. Senator Whitehouse, Providence, Rhode Island, VNA, a 100-year-old operation closing. Senator Stabenow in Michigan, Senator Langford, all across the country, we are seeing closures. It is deja vu for me. I came to Washington in 1987 to prosecute a lawsuit against the Medicare program to restore it to its full, important purpose. I expect it to stay 3 years. I'm still here. As I told Senator Cardin, I've become a Baltimore Orioles fan, who couldn't be. But I intend to stay here until we can finish this mission with all of you to make the home health benefit the true value that it is. So thank you for the opportunity.
Well, you know how to get my attention. All you have to mention Baltimore Orioles.
37 years in Washington taught me some of those things.
Right. Last night, they won in the ninth inning again. Dr. Grabowski.
Good morning, Chairman Cardin, Ranking Member Daines, and distinguished members of the Subcommittee on Health. Thank you for the opportunity to testify today on this important topic. I am here today speaking in my capacity as a researcher who has studied home health care for over 2 decades. Care is shifting out of institutions and into the home. This shift to home-based care is consistent with the preferences of Medicare beneficiaries and their caregivers to age in place. From a policy perspective, a key objective is to provide individuals with the necessary services to not just age in place, but to age in place safely and successfully. The Medicare home health benefit can potentially help beneficiaries to do this. Yet there have been recent reports of access issues, especially in rural areas. I want to focus my testimony today on ways that Congress can ensure strong access to home-based services for all of our beneficiaries. First, let's talk about payment. I want to stress that Medicare fee-for-service home health care payments are generally adequate to ensure access. The 2023 MedPAC report to Congress found Medicare margins have reached an all-time high of 24.9%. Agencies serving rural areas had an even higher Medicare margin of 25.2%. If the Congress is going to address rural access through payment, I would recommend they do so through a rural payment add-on or some other targeted rural policy. They should not try to solve a potential rural access problem through an adjustment to the overall payment system, which is currently paying home health agencies well above costs. Medicare adopted the patient-driven groupings model, or the PDGM, payment system for home health care right before the start of the pandemic. I would argue that it's not yet possible to determine whether and how the model has impacted home health access because we cannot disentangle what changes are due to the PDGM and what changes are due to the pandemic. I would caution the Congress about making major changes to the PDGM at this time. Let's wait for more data. Also, we know that enrollees in Medicare Advantage plans use less home health care, often from lower-rated agencies. Beneficiaries in these plans face mechanisms like prior authorization review and utilization management that are not used in fee-for-service Medicare. Because we currently have a poor understanding of home health access for Medicare Advantage enrollees, the Congress should request a comprehensive evaluation of this issue. Next, we know that labor challenges are contributing to home health access issues. The most direct policy to increase the size of the labor force is through wage increases. Once again, Medicare fee-for-service payments are well above costs, such that most agencies should be able to pay home health care workers the prevailing market wage rate. If there are certain markets where this is not the case, Congress could once again consider targeted policies for home health agencies to use towards the higher cost of labor in these markets. Also, we are flying blind with respect to whether beneficiaries are accessing high-quality home health care. Unfortunately, we have a limited set of validated quality measures in this space. Home health agencies are mandated to collect detailed assessment data, but MedPAC and others have questioned the accuracy of the assessment data because they are agency-reported and not subject to consistent audit or review. The Congress should encourage the development of improved quality measures, including the increased auditing and oversight of the existing agency-reported assessment data. Finally, I would argue that Medicare home health care is necessary but not sufficient for Medicare beneficiaries to age in place. Many individuals receiving care in the community also have extensive long-term care needs. They typically rely on family caregivers, paid help, or Medicaid for their long-term care. As such, there are disparities by race, ethnicity, and income as to who can age in place with Medicare home health care services. I would encourage the Congress to pursue policies to continue to support family caregivers. I would also strongly recommend that the Congress continue to invest in policies to expand Medicaid home and community-based services. And finally, I would push the Congress to expand models that strongly integrate Medicare and Medicaid services for dually eligible beneficiaries. In summary, access to Medicare home health care is generally strong, but there are some steps the Congress can take to further improve access. I look forward to working with the members of this subcommittee on this effort. Thank you.
Thank you very much for your contribution. Thank all of you. We'll start a 5-minute round of questions. A couple things you said are very disturbing, Mr. Dumby. I would intuitively thought that we would see a significant increase in home health care over that period of time, and that would be a success, keeping people in their home environment, less costly than institutional care. But that's not the case. And Mrs. Stein, you got our attention by saying enforce the law. You know, something about Congress, when we pass laws, we like to see them enforced. And the fact that particularly in Medicare Advantage, they look at this as an acute care need rather than a long-term need, I think is pretty obvious when you look at the numbers that are out there and the utilization in Medicare Advantage programs. So how do we overcome that? Because, as I said in my introductory comments, we don't have a really coordinated long-term care strategy in this nation. It goes well beyond healthcare needs. We know that. How do we make the Medicare, Medicaid reimbursement programs and benefits more functional to the long-term needs of individuals who really want to stay in their community as long as they possibly can, but they need to be able to get the services they need? So enforce the law sounds great, but can you expand on that a little bit? And I'll start with Mrs. Stein. I'll give maybe Mr. Dunby a chance. Your mic, please.
I guess I turned it off instead of on. Thank you. I'm happy to do so. The main thing about enforcing the law I meant to really emphasize is to ensure that Congress knows and insists that CMS knows and implements this benefit in a way that doesn't constantly imply and enforce a myth that this is a short-term acute care benefit. There are policies and practices that incentivize the program to be short-term and acute care. And CMS says it all the time. We have corrected myriad handbooks and pamphlets that come from CMS to indicate that this is a short-term benefit when it's not. That myth really needs to be dispelled. Then, the payment model, the quality measures, and the auditing and oversight of the benefit all need to be geared to ensure that people who qualify under the law, they're homebound, they have a physician or authorized practitioner's order, and they need a skilled service, that they can get all the services that they need for as long as they need them. Currently, the PDGM model, payment model, actually creates disincentives for this to be the case. It pays more for the first 30 days of service. It pays more for people who come from a hospital or an institution. It pays less for people over the long term, and if they come from their home, they didn't need a hospital stay. Audits are done for outliers, they call them, for agencies that provide services for more than 30 days. There should be oversight of underutilization, under-provision of services. There should not be a disincentive to provide services for people who need them to maintain or slow decline of their condition.
Let me give Mr. Dunby a chance. What do we do about Medicare Advantage?
Is it there? There's, red always tells me to stop. Yeah, red is on. I think Medicare Advantage offers a great promise for care in the home, but it's a fully unfulfilled one at this point. Medicare Advantage should be one of the strongest partners with home health because, as Medicare fee-for-service has demonstrated, home health services brings dynamic value to the Medicare program, a value-based purchasing program. One of the only ones that was successful at CMMI is in home health, returning billions of dollars to Medicare by keeping people out of hospitals and readmissions to hospitals through home health services. I think the plans need to wake up, read the data and understand the value that's there. And then maybe they could respect home health services not only in terms of utilization, but in terms of payment rates. Right now, Medicare Advantage plans pay about 80 to 85% of the cost of care.
Mr. Grombowski, let me give you a chance on one of the studies that I have looked at on the effectiveness of home health care, studied by the National Institute of Aging, which found that racial minorities show less functional improvement as a result of home health care than white patients, giving us the clear indication that, once again, the underserved community is underserved. Your comments about that?
healthcare is local and very similar to nursing homes. We have 11,000 home health agencies, so they very much reflect the communities in which they operate. And so that huge variation we see across areas shows up in the home health care data. And we need to do better there by not just improving the home health care and giving more support there to these individuals, but also this is about Medicaid, this is about their long-term care. So, and obviously broader community resources as well. Thanks.
Thank you. Senator Daines.
Chairman Cardin, thank you. I want to get into the topic of access as it relates to home health. Earlier this year, the Medicare Payment Advisory Committee reported to Congress that almost all beneficiaries have access to home health services based on data indicating that 98% of beneficiaries live in zip codes served by 2 or more home health agencies. So they're kind of claiming success through that, at least, particular analysis. However, simply living near a healthcare facility does not necessarily guarantee a patient's access to services. Dr. Grabowski, could you speak to the challenge of access in home health and why living in proximity to an agency is not necessarily an ideal indicator of access in this context?
Yeah, I love the way that Dr. Moreau's framed it earlier. It's necessary that you have a home health agency in your zip code, but it's not sufficient. And because you have one in the zip code doesn't mean they're regularly accepting new patients. It doesn't mean they're delivering timely visits. So it's great that we have this strong supply of home health agencies around the country, but it's not always clear that supply alone is an indicator that individuals have strong access. Thanks.
So they're scoring this as a 98, which usually is an A on most tests, but suggests perhaps there's a problem here.
And I can't speak for MedPAC and why they do that, but I think the issue is data. We just don't have the kind of data on timely visits, whether they're accepting new patients, and so the supply is a nice proxy for access, but it doesn't tell the whole story.
Yeah, well, Dr. Grabowski mentioned you, Dr. Moreau's. I think you probably have some thoughts on this as well.
Yes, thank you. So as we mentioned, there is quite a gap between referrals to home health and actually admission to home health. And Ms. Edwards spoke to this point as well. I mentioned that fewer than 60% of beneficiaries with a discharge order from home health coming from the hospital actually wind up admitted to a home health agency and get that care. So I'm 100% a believer that the number of home health agencies that serve a zip code is not going to give an accurate picture. As Ms. Edwards also said, I'll call out as well her personal experience in this with her home health agency. We hear it from our research too, that many home health agencies they don't have the capacity to accept every referral and every admission that comes their way.
So if may not be the ideal proxy, is any thoughts around what might be a better proxy here as we try to evaluate access?
Yes, we need to compare actual rates of use of home health, which we do see disparities, particularly in the most rural communities. And we also need to look at refusals, referrals that are refused. We need to talk to the home health agencies to see how much they're being asked to provide services and whether or not they do that. The one challenge in that, though, is there are communities where they stop even referring to home health because they know their patients are not going to be accepted. So there will still be a gap in measurement, but that's a start to moving towards a better.
Well, it's helpful. There'll never be a perfect analysis, but perhaps better as possible. So we start to look at this to get a more accurate picture of reality. Since 2001, Medicare has intermittently provided an add-on payment for home health agencies serving rural communities through varying reimbursement percentage increases. The most recent rural add-on payment was a 1% increase to home health agencies providing services in low population density areas for the duration of 2023. Dr. Moreau's, we're from the kind of the same side of the country out there at UW. Could you share your perspective on the value of this add-on payment and how it affects the service delivery and accessibility of home health for rural patients in Medicare?
Thank you, Senator Daines. I'd be happy to comment on that. We have found in our research and research from other universities have actually found that the rural add-on payment has great potential to both increase access to care as well as provide the services that they need to provide, reducing hospitalizations. So the decrease and then sunsetting of the rural add-on payment is of great concern. So 1%, our research shows that that's probably not enough to make a difference for home health agencies to be able to serve more rural beneficiaries and to provide the services once they're being admitted to the service. So I think targeting, I will say research also really supports targeting. Rural is not homogeneous. You know this. Anyone that lives in a rural state knows this. Not every rural county is the same. So we also need to make sure that those rural add-on payments are targeted towards those beneficiaries that are truly not going to receive care otherwise.
Lastly, Ms. Edwards, I mentioned in my opening remarks some of the difficulties providers face when operating in rural and less populated service areas. Could you share with us some of the challenges you're experiencing at Mary Lanning and maybe perhaps the best practice you've put in place that might help address these challenges?
Yes, I would be happy to. Thank you, Senator Daines. Our biggest challenge we're the rural, and we still are rural, just covering one county. When we covered those 13 counties previously, that was 42,000 Medicare beneficiaries, not including the pediatric patient population that we serve. We are one of the only home health agencies in our region that take pediatric patients, so that impacts all patients of all ages. Now that we've decreased, there's about 7,000 Medicare beneficiaries just in Adams County, so that impacts a lot of the beneficiaries because some of those counties are still not covered. I would say best practice, the tenured staff we have, they love what they do. They're focused on high-quality care, and we try to accept every referral we possibly can within our area. If we're contracted with their payer type, that's always a challenge as well.
Thank you.
Senator Blackburn.
Thank you, Mr. Chairman, and thank you to our witnesses for being here today. This is an issue I've worked on since I was in the state Senate, how we increase options and choices for seniors, and home health is an important part of that. And right now, what we have found, there are 74,000 Tennesseans that are on the Medicare home health benefit. 87% of those Tennesseans have 3 or more chronic conditions. So these are complex medical conditions, and they require a high-quality home health care. And we are hearing from our providers in Tennessee a tremendous amount of concern about the payment policy that CMS put in place in 2020 and how it is creating some instability and uncertainty in the process for these individuals. And I have visited with many who have looked at how next year's payment rates proposed in June would make matters worse for these patients. And as we have discussed today, and as you all have discussed in your testimonies, seniors want and deserve the ability to be able to stay in their homes. But you look at this payment policy, and then you look at this historic inflation, and also the workforce challenges that we have, especially in rural areas. And you can see that this is creating what will end up being a perfect storm in the most negative sense for many seniors with complex medical issues. And Mr. Chairman, I will tell you, I think CMS should have been at this table today to talk about this payment policy and about this proposed rule. So, Ms. Edwards, let me come to you first. Just for a moment, talk about what would happen to your agency if this rule were finalized and put in place.
Yes, thank you for the question. If this payment policy goes through with additional reductions, I have no doubt that our agency would probably have to close. We've already reduced to the bare minimum that we possibly can right now, and much further would indicate a closure.
Yeah, you can't work without making some money. Mr. Dumby, when you look at small healthcare agencies, and we've got 95 counties in Tennessee, and just about every one of them have a home health agency. They're small. Talk about the impact on these small independent providers that are out there trying to meet the needs in their community, trying to work alongside a rural hospital, trying to work alongside a long-term care facility, and trying to provide the service in home.
I have both the fortune and misfortune of traveling a lot around the country and talking to the home care providers. And the word of the year for them that I heard in Georgia this week, in Texas last week, and other states over the previous weeks is survival. Most home health agencies are, just as you described, small operations. Even the very large companies are very local, small companies in that respect. So their fear and anxiety is growing. And when you look at what they're doing, they're saying no to patients. There's no harder thing for a healthcare professional to do than to say no. And to say no, you're not going to be able to come home. You're going to end up in another institutional care setting instead. That crushes them and crushes their hearts and their souls. And the families are absolutely affected by that as well. And sometimes the no is because they don't have capacity, but a lot of the capacity actually is due to the financial circumstances. A home health agency reported recently to me that they made job offers to 160 nurses, and every one of the nurses said no because they could get paid higher.
Yeah, and those healthcare, the worker challenges are important. I want you to talk for just a moment, too, about the lack of interoperable electronic health records and the impact that this has. Having helped care for someone who was elderly, you see some of these gaps.
And this is very ironic because so many resources have been directed towards physicians in hospitals for interoperable health records. Nothing was directed towards home care, yet home care actually was first out of the gate and ready to go to do health care with interoperable health care records. We have a nurse in an individual's home right at this very moment who has point of care planning with her, either her phone or her iPad. With electronic connections to physicians, to hospitals, to their own office, but they don't talk the same language. The ability to respond immediately to someone's needs in the home setting when something exacerbates in their clinical condition requires that kind of interoperability. So we're looking at it saying, will the rest of the world catch up with us someday so that we can have the full value of those interoperable healthcare records to then provide the highest quality care to the patients as well?
Thank you. My time has expired. Dr. Morose, I'm going to submit a question in writing to you. Thank you. Thank you, Mr. Chairman.
Senator Stabenow.
Well, thank you so much, Mr. Chairman and Ranking Member Daines. So it's very, very important hearing. I've been working on these issues, I think, most of my professional life, and certainly starting in the House of Representatives. I can't thank all of you enough for your very important testimony. For the life of me, I can never understand how, as we move forward on healthcare policy, one of the proposals is always somehow to cut home health care, even though people want more home health care, even though during the pandemic and now afterwards we're seeing increased needs as a result of this, but somehow that's always home health care payments are always a part of the equation, which I think is the opposite of what we should be doing. So I also want to say that we know we have serious workforce shortages that need to be addressed in so many areas, and we need to continue to be doing that. I do have to say I appreciate this support that's been given for the bill that Senator Collins and I have, Preserving Access to Home Health Care Act. I think it would provide the certainty and stability to home health care providers that's needed right now by preventing additional cuts. I hope, Mr. Chairman, we'll be able to move forward on that as quickly as possible. But let me start, Ms. Edwards, with you first. Thank you so much for coming and telling your story and for supporting our legislation. One of the things that I kept thinking about, though, as you were talking, you keep shrinking your service area, right? So you've got 13 counties. Now you have one county. What happens to the rest of the people in those other counties? What's happening for them?
Thank you for the question. They have options for other home health agencies. Many don't serve the full county they're in. Many of them won't accept those higher need patients, or again, like I mentioned before, they might not be in contract with the payer. So a lot of them,
They're just not getting service.
they're not getting service. They're
Or they maybe get really, really sick and they end up in the hospital, right, or someplace else.
If they're referred from the hospital, they might end up staying there longer. We've had patients in the hospital for 40, 50, sometimes 200 days because there's no place for them to go.
And so it really is, it's like the proverbial punching bag, it's right. If we're not providing adequate home health care for people, they could very much end up in the hospital at higher cost care. Or not getting any care and then getting sicker and then something else happening. And so home health care is incredibly important in the equation for people, and it's what people want.
Yes.
People want for themselves and their families. Let me ask Mr. Dumby, in talking about payments, I mean, it's people, but we have to talk about reimbursement because that's how we get the services and pay for the workers to be able to provide the services that people need. Could you talk a little bit more about the current and proposed payment policies that are cuts? I mean, let's just call it what it is. It's cuts. And really what that means for the average provider of home health services.
I mean, as you noted, there is an intimate relationship between payment and service. I'm really tired of talking about payment policy and payment rates, but it's still essential to do so. Medicare's proposal would cut payment rates by 5.653% in 2024, and there's a $3.5 billion quote-unquote debt hanging over the heads of home health agencies right now, contributing to their anxiety. Combine that with the fact that there was a forecasting error in the inflation rate that led to rate changes for home health agencies, a shortage of 5.2% for the years 21 and 22, when particularly labor costs rose significantly. That's now baked in permanently into the payment rate, so that 5% shortfall will continue ad infinitum. CMS has refused to correct that forecasting error. So when we're looking at it, it adds up. CMS added it up itself, $870 million reduction in spending for home health just in 2024. And that 870 will repeat itself over and over and over again for the rest of the Medicare home health benefits life. So we're really talking, you know, some long-term negative impacts as a result of that. And these are on top of cuts that took place in 2023. And so the other thing that stands out is that CMS was required to create this new model in a budget-neutral fashion. It seems really kind of elementary when you see that spending and utilization of home health has gone down from the previous 2019 model of care in 2019. I mean, losing 500,000 patients over a short period of time should tell CMS this was not a neutral transition at all.
Thank you. Thank you, Mr. Chairman. I just want to say in concluding that we know that as we are fortunate enough to be able to live longer and healthcare is allowing us to do that, our needs on home health care are only going to grow. And so we need to right-size this and stop putting patches on it over and over again. So thank you, Mr. Chairman.
Thank you, Senator Stabenow. Senator Cortez Masto.
Thank you. I want to thank the chairman and ranking member of the subcommittee. It's an incredible conversation that we need to have. And I've got a number of questions, but I've only got 5 minutes, so I'm going to try to get through them. But let me caveat it by this. This is such a timely conversation because in my own family, my mother has a first cousin who can no longer live by himself. He would prefer to age in place, but he can't. And I'm assuming, and maybe I'm assuming wrong, but part of the challenge I'm hearing, and maybe, and Ms. Stein, this is why I'm going to ask you to address this a little bit more, is this idea that CMS is enforcing Medicare as a short-term acute care benefit. What he needs is some sort of assisted living long-term care. So here's his option. If he can't get that from Medicare, then he's got to sell his house, take $50,000, $60,000 from whatever he sells, give it to the assisted living, and still pay $5,000 a month to be able for assisted living, and really monitor his own medication. And this is the option we're giving seniors. This is the option for individuals if they can't age in place because they can't access the benefits that we are providing for them through Medicare and or Medicaid. So can I ask, is that part of the problem we're seeing here? Should we be looking at this implementation of the law, that it is incorrectly being implemented by CMS at this point in time? That is part of the challenge we're seeing here?
Yes, it's definitely part of the challenge.
Go ahead.
Audits look to overutilization. If an agency provides care for longer than 30, 60 days, then they are afraid that they will be audited for providing more care than is the norm. And of course, the more that agencies provide care for shorter periods of time, the more the norm becomes short-term. Quality measures are based on improvement so that people who cannot improve in ambulation but may be able to maintain what they have if they have physical therapy come in, if they have aides help them at home, their agencies will not get quality star ratings sufficiently because the quality measures are based on improvement. So we need to have quality measures that show that they've maintained or slowed decline. We need auditing that looks at underutilization, not just so-called overutilization. We need an increase on the cap of outlier payments, outlier meaning people who get longer-term care. And the PDGM, that payment model, needs to be revised so that people who are able to avoid a hospitalization are not less popular to home health agencies because they're paid less to take them from home, and that they're paid less after 30 days of care. So the payment model, the quality measures, and the auditing all needs to be revised so that it looks and tries to incentivize getting the full array of care that patients need for the length of time that they need them.
And does anyone on the panel disagree with what Ms. Stein has just said as part of the challenges that we should be focused on here in Congress? Nobody disagrees with that. Okay, I thank you, because that is exactly what I'm looking for, and I know my colleagues are as well. Let me add one thing to this, and we've talked about it. It's the workforce issue. And let me just couch it in this way. We have the Gwynn Center in Nevada, and it found that Nevada will need 5,300 more home health aides by 2026 to meet the growing demand for home health services. Nevada currently has around 13,000 home health workers, the backbone of our healthcare system. But in Nevada, every county is a designated healthcare workforce shortage area. And so the question is, what else do we need to be doing besides, I agree, I hear from home healthcare workers all the time, we've got to increase their wages and benefits. What else should we be thinking about? What else needs to be done here to bring and really grow that workforce? It is a challenge. Mr. Dombey, I heard what you just said about the nurses and the choices that they're making, rightfully so, based on the wages that they can get somewhere else. What else should we be thinking about here? What else needs to be done?
Yeah, I mean, there are all those kinds of things that involve money, but I want to focus on something that's not. We really need to show respect to that workforce. We need to raise their image, celebrate the heroes that they are delivering the care, recognize that they're more essential to our economy, to our families and everything else than the people who work at Dunkin' Donuts that make more money than they do. But they're not getting that kind of respect that they deserve. I mean, these are caring for grandparents and aunts and uncles and in my age group, people I went to high school with. Yes, Senator, I really am 110 years old. But so it may sound ethereal, but it really does matter. We need to get people to want to aspire to do that work, and I know that Carrie Edwards' daughter, is one of those individuals right now as a high school student delivering those kinds of services. We need more of people like her out there to demonstrate this is a value that our country truly, truly honors.
Couldn't agree more, Mr. Dombey. Thank you. I know my time is up. Thank you.
Senator Whitehouse.
Thanks, Chairman. Our Rhode Island experience through COVID was pretty illuminating about telehealth. There had been a huge row about whether telehealth made sense, whether it should be paid for, a big squabble. When it became absolutely necessary to go to telehealth, period, because of COVID, a lot of the objections and concerns evaporated. The use of telehealth proved itself very quickly, and we leapt through what had been a lot of barriers. Did anything similar happen with respect to home health care as a result of COVID experience? Ms. Stein.
Yes, there was telehealth provided for people who wanted to and could access it in their home. But you know, one of the things about—
And how did that roll into the home health service side of the equation?
It helped on the, for people, for instance, who needed physical therapy and could access video and follow instructions from a therapist in that way. We had people who we knew were getting physical therapy, but if it's wound care, and if it depends on the need of the patient, and it depends on the availability of what tech they have available and how well they can use it. And home health aides provide hands-on personal care, so it's less effective with that kind of care.
One other big shift in Rhode Island was when two of our major primary care providers became ACOs, Accountable Care Organizations.
Yes.
Coastal Medical was one, Integra was another. Both of them were among the highest performing ACOs in the country. And they ramped up home health service delivery on a patient-by-patient basis because it was in their interest, once they were somewhat freed from fee-for-service, to make sure that each patient was getting the best care that they needed to keep them healthy and therefore keep costs down. And so that has worked really well. Mr. Dombey, do you see expanding? What more can we do to have that ACO example improve the experience of patients with access to home health services?
And you're so correct that the successful ACOs have relied upon home health services to their own financial business benefit in addition to the patient benefit. And the learnings from those ACOs is now being transmitted to other ACOs to manage care programs and the like, because it has been, it's been ambitious to bring home health care services to the home, but it's been an underappreciated and underutilized benefit. So a lot of the learning that you've noted that was there is now being passed on to others to see that kind of benefit. So, as I mentioned, the value-based purchasing program with home health in the Medicare program has shown that dynamic value. And so it's taking longer than we'd hoped, but it would really benefit for more to take advantage of it. I want to add to what Judy was offering on telehealth services. During the pandemic in particular, there were millions of telehealth visits done by home health agencies to patients in their homes, working in concert with physicians and nurse practitioners and the like to substitute for in-person services. And they did that in the context of a program that prohibits recognition of the cost of telehealth services as part of setting payment rates for that. So we're looking to modernize the Medicare program and recognize the telehealth.
So my time is getting a little bit short, so I'd ask to any witness who cares to respond in writing as a question for the record, any specific recommendations that you have on how we can use the ACO model and how we can use the telehealth means to expand home services. What are there things that we could do with CMS regs? Are there things we could do with CMMI models? Are there things we could do with legislation that would expand what appear to be two very productive gateways, both for lowered cost and for improved patient care and patient experience? And if I'm not mistaken, the home health value-based program, I don't know if anybody's tracking that on the, it appears to have saved a lot of money. Yeah, I'm getting some nods. So that actually creates, it's not just Rhode Island's experience that a well-run ACO can deliver home health services effectively to people and save money, or that telehealth can facilitate inexpensive home health service delivery. But also, you've got this model program that worked and that created savings.
And we worked in partnership with the Department of Health and Human Services to expand nationwide the value-based purchasing this year. Medicare projects it will save $3.5 billion over 4 years in avoidance of higher cost care, particularly in hospitals for that. So we'd be glad to work with you.
Thanks. Well, Mr. Chairman, it sounds like we know some things that work. We need to do more of them. Thank you for the hearing.
Thank you, Senator Whitehouse. Senator Young.
Dr. Grabowski, I'm going to ask you a series of questions. I ask that maybe you reply quickly. Some of them I apologize if they've been asked earlier today. But you mentioned in your testimony care shifting out of institutions and into the home, and seniors want to be at home, which is no surprise, I think, to any of us. We need to ensure policies support that trend in a sound way, which is one of the reasons we're here today, ensuring appropriate access, quality care, and consistent health outcomes. You comment that there's adequate access to Medicare fee-for-service for home health agencies, but is it timely access, sir?
Yeah, this is such an important issue that supply does not equal access, that obviously we need better data behind are they getting timely visits as you suggest? And I don't know that we know that nationally right now. And that would be great if we could get such a data set.
Noted and appreciated. When a patient's been referred to home health, how long does it take for those services to begin, typically?
They should start relatively quickly. That's actually a measure of quality, like timely initiation of care. So you'd hope within 48 hours.
Okay. Are hospitals able to routinely identify a home health agency for patients when they're ready for discharge?
Sometimes yes, sometimes no. It can vary. There are software where they can sort of give beneficiaries a roster of places, but
and who's measuring this quality outcome?
We know,
and rewarding it, presumably.
We have data on timely initiation of care, but we don't really know refusals. We don't really know the process that happens. That's all underneath the surface.
Okay. Are seniors or families reasonably able to find a home health agency with availability?
That once again can really vary by market, and yes, they can go on Home Health Compare and compare the star ratings, but they don't know if that particular home health agency is accepting patients at that time. So there's a lot of blurriness on the part of, I think, our patients and their family members.
Yes, and we're I think appropriately asking patients to be consumer-oriented, discerning shoppers. We need to empower them to do that, I think.
Absolutely.
Yes,
I'll say very quickly, there's legislation that hospitals, I know not every home health patient comes through the hospital, but for those leaving the hospital, the Congress has put legislation in place that the hospitals should be helping them, but hospitals aren't always doing that, and hospitals don't want to play too heavy of a role in that, but they should be providing information to beneficiaries.
Okay, so we need to persuade them and incentivize them perhaps to comply with existing law, right?
And by incentivize as well, Senator Whitehouse mentioned ACOs. That's a perfect example of an entity that's very incentivized to kind of worry about costs and placement. And there's, as was suggested earlier, there's been a lot of transition out of skilled nursing facilities to home health agencies when you incentivize hospitals under an accountable care organization or ACO.
Thank you, Doctor. Can you speak to the health outcomes for patients that utilize home health compared to those that do not?
No, there's absolutely a benefit to home health. My only sort of tweak, and I said this in my testimony, is that I wish we had better data, and I wish the assessment data were better that the agencies report, because I think oftentimes it's when you track over time, a lot of the claims-based measures that we think are more objective seem to be suggesting stagnant quality or even declining quality, where these agency-reported quality measures seem to be suggesting improvement. And I worry that we don't have a great set of quality measures here.
Sure. what data is missing to ensure patient access to quality home health services?
I think it goes back to a lot of those agency-reported measures like physical functioning. Are they improving? Are they maintaining their physical functioning? So I don't know that we have great accuracy with the current data that are being reported.
Okay, you answered these questions. I see some real opportunities for us to tighten things up, so to speak. You cautioned Congress about making major changes to the patient-driven groupings model, PDGM, that payment system, given this new system was adopted at the start of the pandemic. Based on the design of the payment model, what should we expect in terms of access under the PDGM?
Well, the PDGM, just to back up a little bit, really changed incentives pretty dramatically. Under the old payment system, home health agencies were paid based on the amount of therapy that they delivered. And so, as you can expect, when you pay for therapy, you get lots of therapy. Under the new system, they're paid based on patient characteristics. And so, we should see higher acuity patients being admitted into home health. That would be the expectation. I think it's a little early, given the pandemic, to really track what's happened under the PDGM. So I would just caution Congress about making changes until we're able to move out of the pandemic and really get a sense of how this policy is working.
And then as we come to a close here, I'm going to ask you a two-part question. How long will it take for researchers to, in your words, disentangle what changes are due to the PDGM rather, and what is due to the pandemic? So how long will it take for that? And do you feel there is the potential for access concerns as researchers and CMS navigate post-pandemic data?
So I think it'll take several years here. So I think it'll be over the next several years that we'll get a sense of how things are working. So the next 2 to 3 years when we begin to get data. I hope we're able to look at access. It's got to move, as you said, as you indicated with your very first question, it's got to move beyond supply and utilization-based measures and really look at timely visits, whether agencies are able to accept new patients, what types of patients are being admitted into home health.
Thank you, Doctor. Chairman?
Thanks.
Thank you, Senator Young. Senator Carper.
Thanks, Mr. Chairman. Welcome, everybody. Nice to see you. Thank you for joining us for this important conversation. I think all of us agree that home-based health care plays an essential role in ensuring that everyone receives the care that they need, when they need it, and where they want it. We saw the demand for home-based health care rise during the COVID-19 pandemic. Hospitals and healthcare facilities were over capacity, as we'll all recall. Patients preferred to receive care at home where possible and when appropriate. One program that was established to meet this demand was the Acute Hospital Care at Home Waiver Program, known as Hospital at Home, because it allows Medicare beneficiaries to receive hospital-level health care services in their home. Since its enactment, hospitals and health systems across, I think 34, my last time I checked was 34 states, including my own home state of Delaware, have utilized the Hospital at Home program to provide safe, high-quality, hospital-level services in the homes of patients. The Hospital at Home program has been a true success story. It has delivered positive outcomes. It has delivered a higher reported patient satisfaction, and I understand it has also delivered potential cost savings. Where I come from, that's a win-win-win situation. And to ensure that patients and their providers would have access to the Hospital at Home program for 2 years beyond the duration of the COVID-19 public health emergency. Last Congress, Senator Tim Scott, a member of this committee, and I introduced the Hospital and Patient Service Modernization Act. I am proud that the Congress passed our bipartisan bill, and it was signed into law by President Biden last year. A question initially for Mr. Dombey, and I think for Dr. Grabowski. Same question of each of you. Mr. Dombey, could you please share how the Hospital at Home program has continued to serve patients past the end of the public health emergency?
Well, I'll call it the demonstration program of enlightenment.
I like that.
And I thought of it just moments ago, but
Do you mind if I steal it?
It's all yours. What I mean by that is, we built the Medicare program in 1965 on a continuum of care concept that was setting focused. And the hospital at home demonstration program shows that the continuum of care should be patient focused rather than setting focused. The capability of delivering a high level of acuity of care to individuals in their own home, bringing high quality results, cost savings, and certainly a lot of satisfaction. None of us wants to go out of our home for health care if there's a way of avoiding it. So more than anything else, put aside the technical aspects of the program and the like, it's just that this has created an environment for innovation in the delivery of healthcare that's even wider than the hospital at home program. And that's what I'd love to be able to have conversations with this committee about instead of payment rates, for a program that actually established that care in the home is cost effective, high quality, the home health benefit under the Medicare program. So I'm hoping for, before I'm needing hospital at home services, to be able to have those kinds of conversations.
All right, good. Thank you. Dr. Grabowski, same question. Could you share with us how the hospital home program has continued to serve patients past the end of the emergency?
Yeah, it's an incredibly innovative program. We have a model in Boston, just down the street from where I work at Brigham and Women's Hospital. Some colleagues there have a hospital at home program, and when they actually put it out in the field to test it, they actually had to self-finance it because there was no payment mechanism to support hospital at home for patients in the Boston market at that time. This is a place where I think a lot of the delivery level innovations are maybe ahead of some of the payment innovations that are out there. So I'm also, similar to Mr. Dombey, very excited about this kind of model and its potential.
Good, thank you. A follow-up question, and for each of you, for Mr. Dombey and from Dr. Grabowski. What lessons have we learned from the success of the hospital at home program? What should we as legislators keep in mind as we look toward making hospital at home a permanent program?
I mean, we learned, among other things, the marriage between professional services and technology actually enhances the quality of care. We've learned that we should not hold ourselves back from creativity and innovation and live in the 1965 era of the Medicare program. We should learn also to listen to the providers of healthcare services. It was at Johns Hopkins that hospital at home was born as a concept many years ago. But it took quite a while to take off for that. So I think we've learned a lot, that could be there. And we've learned a lot still as it's unfolding on how we can refine it, improve it, and really make it, the full value that's out there, including how it can be a transition, to segue back to the Medicare home health benefit, a segue back to home health services when an individual's level of care needs are satisfied from the hospital level back to the home health side.
All right. Thank you for that. Same question, Dr. Grabowski. What should we as legislators keep in mind as we look at possibly making hospital at home a permanent program?
Sure. The title of this hearing is Aging in Place, and I think sometimes we have a very narrow view of aging in place. The hospital at home program suggests we should not limit ourselves to very particular models, but think quite broadly, because there's incredibly innovative models that are out there. This hospital at home really, I think, is pushing the envelope, and I hope that policy catches up with kind of some of what's happening at Hopkins and also at Harvard. Mr. Dombey called out Hopkins, but also they may have started at Hopkins. Lots of great work.
He was right to call out Hopkins. That was the right.
Are we dealing with a rivalry here?
All right. Our thanks to all of you. Thanks for joining us today. It's a good discussion. We appreciate it very much.
Senator Hassan.
Thank you, Chair Cardin, and I want to thank you and Ranking Member Daines for having this hearing. Thank you to our witnesses for being here today. Thank you, Senator Carper, for the line of questioning you just had. I would also say that if we can partner with families like mine, which have been dealing with children who are now adults with complex medical conditions at home for an entire generation, there's a lot of creativity and innovation to be had, and I would really look forward in working with these witnesses and all of my colleagues on improving things like hospital at home and implementing them. But I did want to start with a more specific question to you, Ms. Stein. Senators Duckworth, Blackburn, Casey, and I recently urged the Centers for Medicare and Medicaid Services to conduct a comprehensive review of its coverage of mobility assistive equipment, such as wheelchairs, canes, and scooters. CMS currently has a really narrow interpretation of what equipment should be covered and when. We are just talking about, silos and specificity and reference back to very outdated models. Medicare right now covers equipment for daily activities within the home, but many people also need equipment that's more appropriate for use outside of the home. We're asking CMS to reassess this standard to ensure that individuals with disabilities can get the support that they need to live independently and to participate in their communities. So, Ms. Stein, can you speak to how Medicare's limited coverage of mobility equipment impacts patients and their families, as well as the implications it has for individuals' participation in their communities?
Absolutely. Thank you for the question. And I think this is a place where both Congress and CMS need to revise outdated law and policies. As you know, it is said in order to get Medicare coverage for most equipment, prosthetics, and orthotics, they need to be primarily for medical reasons and primarily used in the home. And by the way, the home can't be your SNF, your nursing home. Right. Those things can be changed by, the definition of home needs to be changed by Congress. But the use in the community is incredibly important. And an example of where what we thought were the horizons for people with disabilities have fortunately been expanded. Yeah. So we don't want, nor do people with various disabilities need to remain in home with their equipment. And in 2023, the equipment can often allow them to exit home, to work, to be with family, whether it's mobility devices, whether it's technology so that they can speak, right, which Congress fortunately covered a few years ago under Medicare. These things definitely need to be looked at as CMS has authority under its current mantle to define the medical use and the value of this equipment, where and when it can be used. They should push the envelope with regard to the use of this equipment and standardize equipment so that people can use it given their particular disabilities. And then legislation would be helpful to expand the notion of what's primarily medical use, yep, and to be able to be used in the community.
Well, thank you very much for that input.
I hope that's helpful.
That is helpful. Thank you.
And if we can help you from the Center for Medicare Advocacy, we would greatly like to offer our legal acumen and stories from our clients. This is a very important area.
Thank you very much. We will follow up with you on that. Mr. Dombey, I wanted to ask you a question. As you know, the Centers for Medicare and Medicaid Services is currently working to finalize a payment rule for Medicaid home health services. This rule includes important updates to the Medicaid home care benefit to preserve the quality and safety of home health care. It would require that home health organizations direct 80% of their Medicaid payments towards workers' wages. So I strongly support fair wages for essential workers such as home health aides, but I'm concerned that this requirement may have really unintended consequences. New Hampshire has an unemployment rate right now just under 2%. It's the lowest in the country. Home health organizations face significant vacancies for positions and competition for workers. The requirements outlined in CMS's recent proposed rule would require a level of staffing that simply may not be available in the short term. So can you speak to these workforce challenges and the potential impact of this rule on access to home health care?
We, as an organization, have long supported better compensation to the caregiving workforce, and I think the proposed rule has that intention. Yeah. It's just not a good execution on the intention that's there. We have analyzed multiple states and whether or not their systems would lead to positive or negative outcomes as a result of it. That 20% that's there goes towards such things as supervision, training of the aide, as well as the day-to-day business stuff of billing the Medicaid program on that. So we don't find a single state that could meet that standard. And if they can't meet that standard, what happens with the program is the consumer of the services is on the outside looking in. Right. So we'd certainly like to work with you, work with the White House, and work with CMS to come up with better approaches to achieve the same end. I know Senator Casey, one of your colleagues, has also been very actively involved in this issue, and so I think there's a, so long as there's a will, there's a way, and I think we need to take a different path, but we can get there.
Thank you very much for that, and I thank you for the indulgence, Mr. Chair. I have one more question that I'll submit for the record to Dr. Moroz about the waiting lists, and I appreciate very much this hearing. Thank you.
Thank you, Senator Hassan. And let me thank all of our witnesses again. You could tell by the number of members and their participation that this is an area of great interest to this committee. We understand the importance of home health care, and we recognize that we have not achieved the level that we need for our country or expect. And yes, when the PDGM reforms were put in, it was before the pandemic, and it's made it much more challenging to understand its impact. There's been a lot of changes in our healthcare system since COVID. Its intent was to deal with access and reward for those that have more complicated needs. That was certainly worthwhile and worthy. And it was to be budget neutral. It's questionable was achieved either one of those objectives, and it may very well have cost resources that otherwise should be in home health care. Your observations here are very helpful for us. I think we all are looking for ways to make our health care system more efficient. I appreciate Senator Whitehouse's comments about the ACO plan. That was part of our efforts to deal with that. Telehealth is an area this committee has taken strong bipartisan positions to try to institutionalize a lot of the practices during COVID-19 moving forward on reimbursements for telehealth as a preferred option for a lot of healthcare needs. Certainly in home health can take advantage of that. That's an efficiency with access to care. My own state of Maryland has a total health of care model, the only one in the country that deals with hospital and related costs on the total cost of individuals, which would include home health. So there are models out there that can be looking at efficiency. But one thing we do know that the current reimbursements is having a major impact on the workforce, lack of confidence that there will be a future in government reimbursements for home health services. It has not provided the incentives needed for access to care in many communities. We have a lot of underserved communities, whether they're rural or minority communities. So we have challenges with the reimbursement structure that we need to deal with. So, and then as you pointed out, we look at home health care as a long-term care need. We don't look at it as acute care. That's how Congress set it up, because we want to have a more efficient overall health care system. And yes, we have done a lot in regards to acute care under the Affordable Care Act, but we really haven't taken up long-term care, which is one of the challenges we have as a nation. And this is just one of the reactions to why for not taking up a rational policy of not having the most efficient way to provide home health services that we should. So, as Chairman Wyden indicated, this committee has a strong reputation of working in a bipartisan manner. As you can tell by the questions asked by both Democrats and Republicans, there's really no difference in our views on how we have to deal with this subject. I can assure you that this will be a major interest of our committee, and we recognize that there are urgencies out there. Ms. Edwards, your program and services in your community, obviously, we see it being contracted, and that's not what we want to see. So I just want to thank you all again for your testimonies and contribution to this debate. As is the tradition of our committee, Members will be asking questions for the record. A couple have already indicated, giving you an indication of what that will look like. We would ask that you would respond to those questions in a prompt manner. We have a way of our committee of putting those together and getting them out to you. And with that, there's no further business before the subcommittee. The subcommittee will stand adjourned with our thanks to our witnesses.
Thank you.